Hi everyone, welcome to this afternoon's webinar. I see a lot of people making their hellos and welcomes already in the chat. That's lovely. Thanks for letting us know who you are, where you've come from today and why you've accepted the invitation to attend, and we'll have many different reasons for that, I'm sure. I'll introduce myself. I'm going to be chairing this afternoon's webinar on behalf of the A Better Start Partnership. I'm Deirdre McCalliskey. I'm the Northern Ireland Early Years Lead here at National Children's Bureau, and I lead on our portfolio of work around infant mental health and parenting support in the provision of technical and expert support to the Public Health Agency here in Northern Ireland. So it's a lovely opportunity for me as well to join a bit of our wider work and the contributors this afternoon from the A Better Start Partnership and the associated sites. My role this afternoon, rather than talking infant mental health, will be to create the space for all of you, and I see huge numbers of you coming in already, to hear from the practice across the sites in terms of sharing some of the learning and evidence, the challenges as well, of course, and also to try and share some of the questions that you might have for people based on those presentations. We will record the session and share that afterwards, but I think it's the turning up and being present. That's the critical thing. So thank you and welcome for this afternoon. Welcome to our contributors as well, who will be waiting in the wings for their time slots. Roughly speaking, we'll hear from people for around 10 to 15 minutes. With fabulous presentations lined up, and then there'll be an opportunity for questions that you might send through the Q&A function for me to post some of those for you. Again, that's easiest given the numbers of people that we have. We have to thank as well the National Lottery Community Fund, who have invested in this innovative approach to sharing learning and evidence and improving service development across the sites, and critically to this space in which practitioners themselves can lead practice and share that learning, not just with themselves, but with families, with parents. And I think a nod to the Big Little Moments campaign would be appropriate at this point. We can maybe get a link somewhere in the chat at some point to that. And that's a public information campaign that runs across the sites and takes the cutting edge neuroscience that we now have at our disposal, but packages that in a way so that the basic learning around brain development and how our day-to-day interactions with our infants, babies and children is shaping their development and laying the foundations for lifelong physical and mental well-being. So that's a lovely package, and there's a great toolkit there available on the Lottery website as well. So I'm sure we can look to that as well. I will one last thank you when we get started. They're always better in advance, to all of the technical people behind the scenes at National Children's Bureau and Beacon House who are making this work for us. The plan is for us to be together now up until 3:30 to get the contributions, and those teams will be helping us again filter some of the questions and pick up on things that are asked and shared there in the sessions. I'd love to chat loads about this, and I'm really passionate about infant mental health. When we talk about infant mental health, I think we have a shared understanding around the critical importance of the first 1,001 days and the developing, the evolving and scaffolding capacity of infants and children to form relationships and identify and express emotions and begin to explore the world around them. And I think that's always easiest in pregnancy and really early infancy, just to see how wired for connections babies are. That's really evident physically and emotionally, but it's in those stages of the first year and second year of life that I think some of what might feel like an overwhelming responsibility and understanding of how our interactions are actually shaping the brain development and the health pathways for children. But also I think in relaxing a wee bit into that space too, to remember that it really is the small day-to-day serve and return, shared smile and eye contact and embraces that make the greatest difference. It really is about those small places close to home. So when we hear from our contributors, we'll hear about the different approaches that they have to supporting the sharing of that understanding, and also there's tools and strategies that are helpful for parents and practitioners who are moving into that space, because this isn't about perfection. We know that. Good enough really is good enough, and in fact good enough might be best, and it's about, I think, for ourselves in the afternoon as well, and to our contributors, it's not about creating huge or unrealistic expectations of ourselves. It's about managing relationships and leaning into that place when all of us, any of us who are in adult relationships, will know that so much of this is about rupture and repair. Big feelings are inevitable for small children and for all of us. So it's finding the places to allow ourselves to learn as we go, and certainly parenting is that journey. So we'll be kind to ourselves this afternoon. We'll be compassionate. I'll be careful around my use of time to make sure that our contributors get all the space that they need and deserve. And I think if you take that wee message forward as we go into the afternoon, that really in Infant Mental Health Awareness Week, which is why we're holding the webinar, and I know you'll be giving the contributors your undivided attention, but if you do want to tweet, we're using the hashtags IMHAW21 and including infants. Those are the two hashtags for this afternoon and for Infant Mental Health Awareness Week. But essentially, we're starting from a shared point that relationships are the work here. And so for ourselves in this afternoon, and for the families and babies that we work with, it's acknowledging that children live and learn and grow in and because of relationships. So thank you again for joining us in this brief relationship this afternoon, but long may it continue. And I'm going to take the opportunity to bring in our first contributor. And she is Melanie Far Farmer. She is Development Manager at the Blackpool Centre for Early Childhood Development. And the focus that Melanie's going to bring to us in the first presentation is around community approaches to promoting and improving mental health. So you are very welcome, Melanie. And the next time you see me pop up on the screen, that means your time is up and I'm going to field a few questions to you. Thanks so much.
Thank you, Deirdre. Thanks for that welcome. So welcome everybody, and like Deirdre said, my name's Melanie Farman and I'm a development manager here at the Blackpool Centre for Early Child Development. So we're all here today because we're all passionate about infant mental health, and it's Infant Mental Health Awareness Week. And we know that this year's theme is about addressing the baby blind spot. So I would like to share in this session with you today how the Blackpool Better Start Partnership is including infants in children and young people's mental health. So we're doing this by offering what it says here on the slide, a community-based approach to improving infant mental health. And I'm going to highlight some of our approaches. For example, our community connectors who offer peer support, our work with our dads, our universal baby steps offer, and our enhanced health visiting, as well as giving you a flavour of a new service that we're developing and how we're co-producing it. So in essence, I would like to convey that infant mental health is about so much more than just specialist services and that are harder to replicate. Next slide, please. So this is what I'm going to cover today. We're just going to look at 4 things. It'll be a bit of a whistle-stop tour. So we're going to look at infant mental health in Blackpool, the interface between perinatal and parent-infant services, developing a parent-infant relationship service here in Blackpool, and the importance of co-design and co-productions. Next slide, please. So many of you joining here today will already be aware about Better Start. However, for those who may not, I'd just like to share briefly some insight and put some context to what we're going to talk about. So Blackpool was chosen as one of only 5 locations in the UK, and you'll be hearing from our other colleagues across the country at the other 4 sites. We were chosen to receive the big lottery funding of 45 million to help give the town's babies a best start in life. So this initiative aims to have a significant impact on investment in services for babies up to the age of 3, and will enhance support for parents and young families across Blackpool. So we're now in year 7 of 10 years of Blackpool Better Start, with funding invested in evidence-based programmes that have been researched, tested, and are proven to really make a difference to children's well-being. With approximately 1,600 babies we have born in Blackpool each year, Our vision at Better Start is for the Blackpool to be a place where families thrive, where they raise happy, healthy children who take pride in belonging to their community. Next slide, please. So a further area of Better Start that I think is really important to set the context today is just to take you through our theory of change and how we frame all of our work. From the beginning, the partnership had an overarching theory of change, which you'll see here on the slide. And if the stresses parents face were reduced and they were supported to increase their capacity and capability to parent, then this would lead to improved child development outcomes. It would crucially provide children with those firm foundations at this critical stage in their life from which to grow. All of our programs and everything that you'll hear about today do have their own individual theories of change. However, they all link back to this overarching model to ensure that we've got that clear linkage. Next slide, please. Thank you. So let's go to our first point about the infant mental health here in Blackpool. So it's important, we feel, and Deirdre touched on this earlier, that we have a shared language and understanding of babies' mental health. So I felt it was of value when talking about babies' mental health in Blackpool to share how we are defining this. So we've chosen to use the Parent Infant Foundation definition that you can see here on the slide. So I'll just give you a moment to read that. So our vision is for all babies in Blackpool to have a sensitive, responsive and trusted relationship. As we know, this is fundamental to infant mental health, as early experiences affect not only babies' emotional well-being now, but also how their bodies and their brains will develop in the future. And one of the ways we achieve this is through our approach to not only infant mental health, but also perinatal mental health. If we could just move to the next slide, please, thanks. So on this slide, this just gives you an illustration to show our approach here in Blackpool to perinatal and infant mental health. And you'll see there that at the bottom, that underpinning everything is our community approaches. So we're going to touch on those today, and you'll also hear a little bit about our emerging parent infant service. Next slide, please. So this slide just highlights the 4 things that we're going to chat about in relation to our infant mental health approach. Our universal baby steps, our community connectors of peer support, local parents, our health visiting service, and how they really support infant mental health and how we engage our dads. Next slide, please. So moving on to the first thing, we're just going to touch on our universal antenatal education programme, Baby Steps. So Baby Steps, the key of Baby Steps is all about relationships and thinking about reflective functioning. So we know that good, strong, healthy, nurturing relationships early in life really support the development of a secure attachment, and they provide a buffer to life's challenges that are thrown at us, but that provides protection. Life is about relationships and forming relationships early. It starts early with our parents or main caregiver, and then to our peers and our community and wider society. The better these relationships are, the better our mental health. So Baby Steps can really help with this process of relationships, because relationships is at the heart of everything in Baby Steps. We have 3 aspects. They focus on strengthening parent-infant relationships, strengthening couple relationships, and building strong support networks and helping parents to really bring that relationship with their baby to life. Who we are as human beings is created in those moment-to-moment interactions that babies have with their parent or primary caregiver. Next slide, please. So on the slide here, you'll see all of our connectors. We've got community connectors, health connectors, and our dad's connectors. Let's think for a little about those words, community and connectors. This makes me think of the word Ubuntu, which means humanity. It's a philosophy that focuses on I am because of who we all are. We're all connected, and that one can only grow and progress through the growth and progression of others. It's used as a reminder for society on how we should be treating others. Oneness. As a society, we're looking after one another, and it plays a major role in the success of our humanity. Our connectors do this because they look after our local parents by connecting them. Our connector team, like I said, has the 3 elements to it, and they're local parents who are advocates of our work, values and principles, and they're trained to connect with families so they are better linked to other families and the community resources that they need to make positive parenting choices for themselves and their children. Connectors are pivotal in sharing public health messages. And infant mental health is something that we can all think about and not just for professionals. So our connectors really help with this because they help parents to think about things like their baby's mental health. And they've been able to do this all throughout lockdown. And they've done that by connecting with our families on doorstep deliveries with our new parent packs. So the connectors go out to the families and they're able to chat on the doorstep about simple ways that parents can form close relationships with their babies and help their baby to recognise and express emotions, explore and learn their environment, and help build their baby's brains. So furthermore, evidence from the recent work of the Duchess of Cambridge survey really found that the importance and value of peer support, and particularly the element of no judgment being really important to parents, because in the survey, 70% of parents reported feeling judged by others, and among these parents, nearly half felt negatively impacted by their own mental health. So our connectors really do offer this non-judgmental peer support, which is so vital. And additionally, they can signpost and support our families to access activities that support parental and child well-being, such as engaging in parks and open spaces, where they can meet with other parents and their children through our early park rangers activity sessions. And it really promotes that whole family, physical and mental health well-being and connections with other parents and their local community. Next slide, please. So on this slide here, you've just got the illustration of our enhanced health visiting service, because we know that health visitors play a key role in supporting parental and infant mental health. And our health visitors are all trained in the Bradford newborn behavioural observation approach, and they also are trained in, some of them are trained in supporting low mood in the perinatal period by using something called the behavioural activation programme. And this means that where a mother within the first year after birth is experiencing low mood, she can access support straight away. So the suite of support provided by our health visitors includes support for new parents in understanding how their baby is communicating through relationships tools such as the newborn behavioural observation tool. And they really do support parental mental health, because that helps parents to understand why a parent might struggle then to form that bond with their baby, and it can help enhance that if they get the right care at the right time. Next slide, please. So moving on to the final aspect of our community approaches is our engaging dads. So on the slide here, you'll just see the illustration of our key components of our dad strategies. So our community approaches to infant mental health really is focused on engaging our dads, because over the last 20 years, we know from the research there's really been increasing interest and investment in the impact of dad's role in perinatal and also early years period, because of the impact it has on child outcomes. and research indicates that attachment can positively impact the child's development in a variety of ways. Those physical and emotional aspects of parental involvement in child infancy is the really most powerful in influencing child later behaviours. So we've set out in our dad strategy a call to action and a commitment from our partners to ensure a consistency of approach and a promotion of key messages when they're engaging with dads. So we've also, throughout lockdown and carrying on, we set up a Talking Dads Facebook live sessions, and we've been able to open up conversations with our local dads and their families about building their relationships with their babies. And sometimes we know that parents need extra support, either for their emotional well-being during the perinatal period or for difficulties in that building that parent-baby relationship. Next slide, please. So we're just going to look now briefly at the interface between perinatal and parent and infant services, because in Blackpool, as part of our perinatal and infant mental health approaches, our partners in community identified a gap in our offer, which was the need for a parent-infant relationship service. And our families in Blackpool currently do have access. We're very fortunate to specialist perinatal mental health services. And as part of the long-term NHS long-term plan, the specialist perinatal mental health services have extended their remit, which includes additional support for parent-infant relationships. But what we wanted to do right from the start, because we want families to have sort of a cohesive service when moving between services. So we're working really closely with our local specialist perinatal services at the very start and beginning, before we set up our parent and infant relationship service, to make sure our pathways align and we understand where we interface, so that families do receive the right care at the right time by the right people. Next slide, please. So this just gives you a flavour of some of the things that we're thinking about in our third point when we're talking about our emerging parent-infant service. So we're working closely with one of our local commissioners and our partners to set up our parent-infant service here in Blackpool. But critical to this new service, we feel, is about it being inclusive and accessible. And we want to break down the fear and stigma that can often be found from parents, they've said, about disclosing both perinatal mental illness and or troubled parent-infant relationships. So we're working really closely with the Parent-Infant Foundation to inform this work, but also to endeavour to work alongside our experts by experiences within our community to ensure that we have meaningful co-design and co-production. And we're just going to touch on the next slide some of the ways that we're doing this. So it's really important with all of our work here in Blackpool to have co-design and co-production, because it's embedded in our core ethos of Blackpool Better Start, is that aspiration to mitigate the impact of early adversity by building resilience and reducing the intergenerational cycles of poor outcomes. And this cannot be accomplished without us having a co-produced approach. And we want to think about this when we were setting up our parent-infant relationship service. So we're wanting to embed this ethos and this way of working throughout our design, development and delivery of our services and programmes, all the way through to our procurements and contracts, because this commitment allows us all to work together with a shared vision right from the start and a common goal. So because we know that investing in infant mental health and working in this co-design, co-produced way really will have dividends for generations to come. So some of the ways that we've been doing this is by involving our experts by experience in our steering group. And then we've also got a part of our task and finish groups. But just as I shortly draw to a close now, today I've shared with you just a brief overview of our community-based approaches to improving infant mental health, because we believe as a community in Blackpool, we all want to work together to achieve this commitment and play an active role today in working together to raise awareness of babies' mental health and really address that baby blind spot. Thank you. Next slide, thanks. So thank you so much for listening, and I think we've got time for questions, and my details and the details of all of our work is on the slides there. So I hope you've enjoyed this, and please get in touch if you'd like any more information. Thank you.
That's brilliant, Melanie. Thank you so much. There's so much to get through in a few minutes. There was a question there in relation to the types of services that are run across the site, but I think a colleague has answered that in the chat and put up a helpful link there to where people can find that. I'm curious around the co-production and co-design, because I don't want to say they're buzzwords, but we're all talking about them. So what does that look like in practice, whether that's in scale or, what are the voices that you're hearing or reaching or missing in that? It'd be really lovely to hear a wee bit about what's happening there in a really practical basis in the emergent service that you have for parent and infants.
Yeah, absolutely. You're right about the words, and I think language around this is really critical, and it's understanding that what we mean when we talk about that. But some of the practical things that we're doing here in Blackpool, like we have our local parents who are community connectors, but we've also got community voices who are parents who engage with us, but also we reach out through our social media and also through our wider network, through our comms. But we're doing with our parent infant relationship service, we're specifically focusing on having activities that families can join in. So some things like with services, we need to know from the start, families wouldn't be able to change things because, say, a service specification might be a national service specification. So we set things like that out at the start, but we identify areas with our parents and our community, and we meet with them and say, these are the types of things. That's how we know that around the fear. Parents have shared with us about the fear of the stigma of accessing a service such as a perinatal or parent infant services. They're going to be involved with the naming of the service. So we're calling it the parent infant, but that won't be its name. That's just the term we're using, because we want people it to be something that they can relate to, and the language means something to them so that they can understand it. And I think that's important when we're thinking about babies' mental health, isn't it? We're trying to use that term babies, like we've done a Better Start TV show earlier in the week where we changed, because infant not everyone understands what that means, and that's maybe why it's some aspects are a blind spot, like within children's and adolescent mental health, because the baby isn't even there in the words. So it's understanding what we all mean by those. So those are some of the ways that we're engaging. And there's lots more we could say as well, but people can get in touch. I know we're very keen. We're going to do some work with the Parent Infant Foundation all about engaging and co-design and co-production in parent and infant relationship teams. So feel free to get in touch and join our groups with that.
Great, lovely. There's also an interest here from some of the attendees around the community connectors model. Who gets involved, how is that peer support, and what support then becomes available to those peers, if you like? How does that work, Melanie?
Yeah, so with the community connectors, they're all parents that are in the local community, and many of them have come through our volunteering and engaging in all our activities, like our co-production work. And then we've built a bit like think of like a social prescribing essentially, and they then become employed and they work in our community and work with us in a paid role. So I hope that gives answers the question.
Brilliant. That's interesting too. That has to be of benefit in terms of how the community views and values themselves and seeing that work is paid as well, because I think typically it's not. And just, I have a question, this is the joy of being chair, around the enhanced health visiting service as well. You mentioned a tool called behavioural activation, which I'm curious about. You can tell me a wee bit about that. And I wondered as well, does that enhancement come with a reduced caseload to allow people to build that relationship? And actually, we've heard that in the Northern Ireland context. I've heard that from midwives as well, who've said, when I've worked in the hospital context and then moved into the community, I realized I'd never had a conversation with a mum. I asked all the questions I had asked. I checked everything I had to check. I made sure her baby left the hospital safely, but I'd never had the opportunity to engage in conversation. And that's what's developing the architecture of our brains, never mind our baby's brain. So I'm curious to know what that, what some of those tools and techniques you are using look like, and how that's experienced by health visitors in terms of maybe different caseload.
Yes, no, good question about the caseloads. So yeah, it's a pilot at the moment. We've trained 5 health visitors with Heather O'Mahan for the University of Exeter, and because she's done a lot of research into behavioural activation, which is a 6-week short course for mums with low mood, and we feel that it would be of real value for health visitors to be trained in it, because it means that it's all about looking at those relationships and changing the way. It's a bit like behaviour change model, and so it's a short term, and it fits very well with the health visiting model, because normally health visitors would offer listening visits, and it fits with that model, and they can then access that care straight away. So the health visitors are already undertaking those emotional well-being questions through, say, the patient health questionnaire and the generalized anxiety disorder questionnaire. And at that point, if they felt that with the PHQ-9 that the mother would benefit from and get value from the behavioural activation, if she's experiencing low mood in that perinatal period, that can be offered to the family, the mum there, and to start straight away without the need to refer on to another service. So it's something that, yes, watch this space, and we'll be able to feed back about that research, because it's definitely early days, but it's one of what we feel will be a strength of our community approach to perinatal and infant mental health.
Lovely, Melanie, you've been so generous in answering those questions and modelled the good behaviour for us and keeping to time, which I now need to do. Thank you so much. I'm going to welcome our next contributor. Ben Yo is a child and adolescent psychoanalytic psychotherapist, because that wouldn't trip up a chair. And he is from the Parent-Infant Relationship Service at LEAP in Lambeth. And I'm going to hand over to you, Ben. I know the presentation is titled Bringing the Unborn Baby into View, so that's sparked my curiosity already. So thank you, Ben.
Thank you, Deirdre, and thank you, Melanie. So what I'd like to start to do really is to give a very brief overview of our service, and I'll return to this later, because I want to dive straight into the main theme of the presentation today, which is bringing the unborn baby into view. So next slide, please. There we go. So at Pairs, we're really proud to be part of LEAP, the Lambeth Early Action Partnership, and CAMS. We are a small multidisciplinary team. We work with families and children aged pre-birth up to 4 years old, and I'm going to focus on the earliest part of this age range today. And we also support the workforce, Lambeth workforce, through training, consultation and supervision. Right, I'll speak more about that later, but what I'd like to do is to begin with 3 observations which really bring the unborn baby and parental relationships with the unborn baby into view. And I'm going to start with a baby observation. So next slide, please. Baby G was lulled by her mother's regular and drowsy breathing. Her passiveness was in contrast with the almost incessant activity of her tongue, moving in and out of her lips and rolling as if she was sucking it, together with frequent opening and closing of her mouth. Next slide, please. Such closing, though, even when her tongue was not in the way, was always incomplete. And since the image of her umbilical cord, when visualised, was adjacent to her mouth, presumably baby G often kept the cord in her mouth and licked it too. Next slide, please. I was blown away by this observation, which at first, I don't know whether you're like me, but you think it's a postnatal baby, but in actual fact, it's a baby in utero. And it's part of a groundbreaking study many years ago, actually, by the Italian psychoanalyst Parental, who did ultrasound observations of babies, which she then followed through postnatally. Now, I'm starting with this today, not because PEARS does ultrasound observations, at least not yet, but really to emphasize that the unborn baby has an experience. And the study shows that behavior patterns in utero can carry through postnatally too. And what we see at PEARS is how the parent-infant relationship begins prenatally, and that the baby is an active part of this. And I'm thinking of a mother that I was working with recently, and she felt very overwhelmed and intruded upon by her very active 4-year-old child. And this relational dynamic started prenatally. So when the mum felt the kicks of the baby in the womb, she experienced these as kind of too much, too often, and just very overwhelming. And the next observation shows another example of a difficult beginning in the parent-infant relationship. So next slide, please. Thank you. So this is a transcript from an ultrasound observation at 14 weeks from the same study. So the doctor, here we are now, the anterior wall of the womb, the placenta, the gestational sac, the mother. Is it already possible to see the placenta? It's anterior, but at this gestational age, the placenta takes up an extensive area of the internal wall of the womb. Mother, but anterior means normal or not? Anterior is normal. Next slide, please. Is it possible to see enlargements, the details? Well, this is the maximum enlargement. The fetus is moving, isn't it? When will I start feeling its movements? So next slide, please. This is a transcript where we can hear a really anxious mother, and understandably so, because she'd previously experienced a stillbirth. And the anxiety felt very overwhelming in relation to her baby. And this relational dynamic continued postnatally. And we have here an observation at 2 months. So while feeding him, his mother never looked at him, the baby, and spoke relentlessly with me, the observer. The most striking feature about him was the immobility of his body, his eyes, and his face. And here we see the baby's response to these kind of high levels of anxiety, which is really to switch off and disconnect. And this is something we see quite a lot at PEARS. So next slide, please. The third observation is a brief clinical vignette about a father who I was working with who was really unable to focus on the pregnancy of his second baby. And this was causing great distress in him, but also relational difficulties with his partner. And what emerged during the treatment was there was an unacknowledged trauma of the first birth for the father, and also a wider pattern of difficult births in his family across the generations. And I wanted to share this today to remind us that there is a father, something that can be forgotten in the perinatal period. And the father also has a relationship with the unborn baby. And also the relationships around the baby, so the parental couple, are also really significant for the unborn baby. So we know, for instance, if there are high levels of parental conflict, this can actually alter the baby's stress response in utero. Next slide, please. So I wanted to give you a flavour of how we at PEARS think about and formulate the early relationship with the unborn baby. So history is really important. And we can see from my examples that previous pregnancies, birth experiences, but also intergenerational issues are crucial. And the idea from the psychotherapist Selma Freiberg that there are so-called ghosts in the nursery is highly relevant here. And there's actually a Swedish study that shows that emotional warmth experienced by a woman with her own mother during childhood was positively associated with the development of affection towards her unborn baby. We also understand that there's physical and emotional connections. And the psychoanalyst Winnicott talked about a holding environment that parents provide, which is both physical and emotional. So in terms of the unborn baby, we might think about the way parents touch, talk, feel, even sing to the unborn baby. Another crucial element is a kind of cognitive relationship and what we call parental representations of the baby. So what does the baby symbolize or mean in the parent's mind? And there's plenty of research which shows the importance of these so-called parental representations and the later attachment security of the child. So talking of research, let's have a look at the next slide, please. We know that this early parent-infant relationship is vitally important. So in the short term, the quality of the parent-infant relationship, or prenatal attachment, you could say, impacts parental health behaviours in pregnancy, which literally shapes the baby's brain and stress response. In the medium term, the quality of this prenatal relationship can predict the quality of parent-infant interaction in the postnatal period and the infant's attachment status at a year old. And I think we all know the importance of attachment for children as they grow up, so I don't need to go into that. But I suppose what I'm trying to say is that this early relationship, it can be a crucial early warning sign for us as practitioners for later relational difficulties for the child. So next slide, please. So despite its importance, I want to suggest today that there is actually a baby blind spot, particularly for the unborn baby, and this is evident across multiple layers. So if we have the next slide and the next slide after that, two at once, please, thank you. So the first layer is in the commissioning of services, and the early relationship is really out of focus of CAMS, where the child or young person is the priority, and also out of focus for adult mental health perinatal teams, which focus predominantly, not exclusively, on the vital interactions or vital interventions for the adult. But the baby and the early relationship can be a bit out of view. And the Parent-Infant Foundation estimates that 300 parent-infant teams would be needed to meet the needs of infant mental health across the UK, and currently there are 36 teams. So next two slides, please. The next layer is the professional network, and it can be really difficult for us as practitioners to find the right language really for this earliest infant-parent relationship. And in times of crisis, the focus tends to be on the adults. The psychotherapist Margaret Rustin wrote an excellent article about the idea of a defence against mental pain, and how as practitioners we can turn a blind eye to the suffering of children. It's just too difficult to see. And this is particularly relevant for safeguarding. Next slide, please. Now, this next layer is something we see a lot clinically at pairs, which is how parents can actually have a blind spot for their unborn baby. And I wanted to give you a couple of examples. So on the next slide, thank you. A colleague of mine was working with a mother who had high levels of anxiety and also tocophobia, which is a fear or phobia of childbirth. And it was so strong that the mother couldn't bear to even use the word baby. And when she had a bath, she needed lots of foam to cover up what she felt was her disgusting bump. Next slide, please. After a late miscarriage, mother was pregnant again, but mother and father were unable to think or prepare for their unborn baby. Their thoughts were still with the loss of the previous baby and the overwhelming feelings of grief and shame about that. Next slide, please. So what we're interested in at Pairs is how these patterns of relating, or indeed not relating, between parents and their unborn child can carry through postnatally. And what we sometimes find is that babies who are not held in mind prenatally might struggle to articulate their needs and to find a voice postnatally. And if we go on to the next slide, we can see that the baby blind spot extends to the baby or young child themselves. And I wanted to share an important quote from the psychotherapist Sue Gerhardt on the next slide, please. So if such babies could speak, they'd be saying, "Don't worry, I won't bother you." They sense that their dependence and neediness is unwelcome, so they learn to hide their feelings. In fact, they grow up believing implicitly that they shouldn't really have feelings. And this may develop into a difficulty in recognising one's own feelings. After all, if the mothering person, or I would add fathering person, is not interested in them, then how can the child be interested in them? And I think we all know that these are the kinds of children that might end up in CAMS or in adult services later in life. In the last couple of minutes, I wanted to focus on pairs and the approach that we take in this early relationship. So next slide, please. As a service, we have various strands or layers to our work, and our direct clinical work, the parent-infant psychotherapy, is something I'm going to focus on. But we also have our group offer. Currently, we run Circle of Security and Together Time groups, neither of which are prenatal, but we supervise the excellent Baby Steps practitioners who deliver a perinatal educational programme for expectant parents, and I think Melanie mentioned Baby Steps. We also offer consultations and training for practitioners across Lambeth, where we aim to raise awareness for the importance of the earliest infant-parent relationship. And if we go to the next slide, we can think about our direct clinical work. So parent-infant psychotherapy is where we work in the parent-infant relationship prenatally and postnatally. And we're getting an increasing amount of referrals in pregnancy. Any referrals we accept, we do an in-depth comprehensive assessment where we consider the history, as I've talked about, the current relational dynamics, thinking about the quality of the relationship, what are the conscious and unconscious dynamics, what are the relationships like around the baby, and we always try to involve the father if there is one in this assessment. We also use different measures to assess the relationship, and actually looking at the slide, what I actually meant to say was it's the maternal and paternal fetal attachment scale rather than the object relation scale, which is something we use postnatally, so apologies for that. We also think about the different risk factors coming to bear on the parent-infant relationship. And in LEAP areas, there's a higher prevalence of many of these factors, including deprivation, parental mental health difficulties, isolation, domestic violence. And of course, sadly, many of these have been intensified during the pandemic. Then in terms of the treatment, our focus is the relationship and trying to amplify the voice of the baby and young child, helping the parents understand their feelings and emotions towards the baby and vice versa. And these feelings can be conscious and unconscious. So for example, in the case study of tocophobia I mentioned earlier, my colleague helped the expectant mother to make links with her own past. As a child, the mother had been essentially pushed out of her mother's lap when her mother was pregnant. And later on, her younger sibling died, and the mother, as a child, felt terrible guilt about this. So in the here and now, when she was seeing her bump, the mother with tocophobia was actually seeing her mother's bump, which was enormous as she remembered it. And she also kind of was seeing this sickly baby inside. So the therapeutic work was about helping the mother see and accept really the actual baby in her womb. And in the treatment, we also think about ourselves as practitioners and how parents and babies relate to us, what this stirs up in us. And all of this can give us really important clues to the quality of the parent-infant relationship. Next slide, please. Something that underpins all of our work really is the importance of building a team around the parent-infant relationship, and this is crucial for safeguarding too. And I think this is a great quote from another service. So the potential complexity of factors involved from conception through to early life is such that no single practitioner or intervention can be expected to meet the family's needs. Now, often this team around the parent-infant relationship doesn't exist, or it can be more focused on the adult rather than the infant or the parent-infant relationship. And I think we're quite lucky at PAIRS to be part of LEAP, which has many excellent services which we can link up with. And also more widely, we're trying to build relationships in Lambeth with other services such as the perinatal team. So in the spirit of building a team around the parent-infant relationship, I wanted to end by saying that PAIRS is available to all Lambeth practitioners and services for consultations, where we offer thinking space to consider the infant's perspective in the parent-infant relationship. And we can only bring awareness to the baby blind spot by working in a multidisciplinary and multi-agency way. And I look forward to any questions that I'll do my best to answer, or give good enough answers, but I also look forward to hearing from your perspectives and your contributions too. Thank you.
Thank you, Ben. It's fabulous. It really was thought-provoking contribution, complex, as you say. And I found myself needing to restore my own capacity to think as chair, because you bring us a lot there to think about, because you're essentially in a therapeutic relationship with parent and infant. And for those of us who aren't, for me, certainly around this relationship with the unborn baby, and love the phrase that you used, unborn baby blind spot. Are there, again, you touched on at the end that this is a kind of whole community and a whole service and multidisciplinary approach. For those of us who aren't there at your therapeutic end of the service, are there signs or experiences or responses in that relationship with the unborn baby that we can be alive to, that help families find their way to you, if that makes sense? What are we looking for?
I think that's a really good question. And I mean, one of the things I mentioned is about using ourselves as, our own feelings as practitioners and what gets stirred up in us. So we might think that something doesn't seem to, sit right or feel right, and that's often a clue that perhaps there's something amiss in the relationship. But also I find there's something called the working model of the child interview, which has different categories for how parents might talk about their unborn babies. And what we're ideally looking at is for a category of like a balanced description of their unborn baby, which is kind of a quite a fluent description of the kind of positive and negative feelings that they might have towards their baby. So it's all about ambivalence, you know, being an expectant mother or father, we're looking for a realistic sense of ambivalence. If there's too much negativity or that it's totally idealized, then perhaps you'd want to think a bit more about that, and that might be an early warning sign that, you know, the baby's not quite being held in mind realistically.
Brilliant, thank you, Ben. You touched as well earlier in the presentation on fathers, and that's a kind of a thread through a number of the presentations today. And there is a question from one of our participants around the extent to which we understand or have even invited an understanding of fathers' emotional experiences in that journey, pre and postnatally, and whether we have enough evidence or whether there are studies that we might point people to around our understanding of attachment and fathers.
I mean, it's something I personally feel quite passionately about. I think there is a bit of a father neglect, and I know that we're going to be, hopefully future presentations this afternoon are going to be looking at that. I think there's more research that is needed around the father's relationship with the unborn baby. But there are studies that show that just like mothers, expectant mothers, fathers go through psychological, physiological, hormonal shifts and changes in that kind of, you know, pregnancy period. But also there are studies that show that, you know, a father's involvement can be correlated with things like kind of a preterm birth. You know, there's a positive correlation between a level of father involvement and those protectiveness against kind of underweight babies and other kinds of things like that. So there are some studies out there, and I'd be happy to share research on that, but I think it's an area that really needs developing, actually. And for fathers not to be only seen for their presence or absence as a statistic, but actually to think about the subjectivity of fathers, that they are a thing in themselves. They're not just the partner of the mother or the father of the baby, but trying to understand about what it actually means and feels like to be a father of an unborn baby.
Ben, thank you so much. There's a lot of activity in the chat. In the interest of time, can't go everywhere there is, but I think people are really generously sharing some other resources and directing people to some other services and materials that might be useful. So please continue to do that over the course of the afternoon. Ben, thank you so much. It was just fabulous. I'm going to welcome Matthew Price as our third contributor. Matthew is a principal clinical psychologist and he's also the infant mental health pathway lead at Bradford Better Start, and he's going to speak to us about the Little Minds Matter project. So Matthew, I can see you on screen. That's perfect. I just said check you were there. I will mute myself and let you get on with your presentation. Thank you so much.
Thank you very much, and thank you for letting me be part of today. So my name is Matt Price. I am a clinical psychologist, but I also spend a lot of my time thinking about infant mental health pathways. I lead the Little Minds Matter Bradford Infant Mental Health Service, and Little Minds Matter is a Better Start Bradford project. So we're funded by the National Lottery Community Fund. We also receive some additional funding from the Youth in Mind in City programme, which is funded through our CCG. And we're delivered as part of CAMS. So I'm going to say a little bit more about kind of where we sit organisationally and what that means for pathways, and ultimately what that means for the baby blind spot. If I could get the next slide, please. So in addition to thinking about kind of the local context and the services that are available for babies, I'd also like to, I guess, share some of the challenges around accessing services that practitioners and families might experience. And I guess to share just our local experience of trying to navigate some of that and trying to tackle some of that. I was really pleased to hear at the start of this that we're not looking for perfection and that good enough is good enough, because I think that's very much what we're trying to achieve here in Bradford, as I hope that you'll see through my presentation. If I could get the next slide, please. So I'll just step you through the Little Minds Matter service to give you a flavour for how we work. If I could have the next click and the one after that. So just like the other services, we're a preventative, early intervention and prevention service. So we're very much focused on the parent-child relationship. And just like Ben was describing, we work with kind of mums and dads, anyone who's got a key relationship with a baby. And if I could have the next click, please. We offer 4 main strands to our service. The first is training, so trying to upskill the workforce to be better equipped to notice babies, to think about their needs, and to understand why the first 1001 days in life are so critical. We also offer consultation, so really helping people to put the training into practice, to apply some of their newfound knowledge and skills with families that they're out there working with in the community. The third strand that's on this slide is around community engagement. We like to think of this as the public health arm of our service. So if we were to try and spread the key message to everyone in our community, not just those who are in need of services and not just practitioners who support families, community engagement is how we do that. And I'm really excited to share that we've just launched a social media campaign called Moments That Matter. So please do follow us on any social media platforms that you're on, and we will be sharing key messages about infant mental health on Instagram, Twitter, and Facebook. And then last but not least, direct clinical work. And I think Ben gave a really lovely explanation about how this works in practice. We're a multidisciplinary team too, so we've got clinical psychology, family therapy, health visiting, midwifery, counselling psychology. So we've got a really well-rounded team to try and meet the diverse needs of the families that we're trying to support. And if I could get one last click. In terms of the kind of reasons why people might get in touch with us. It might be that the parent is pregnant. And again, I think Ben gave a really lovely set of examples about some of those difficulties that parents might get into in pregnancy, or where the baby is under the age of 2. And what we've wanted to describe here is that it might be that the caregiver is struggling to bond. So they might be saying things like, I just don't feel as connected to this baby as I expected to. Or it might be that as we pay attention to the baby, we notice some signs of distress. So for example, an obvious example would be that kind of baby is difficult to soothe or is particularly kind of withdrawn. But it might also be that baby is overly independent. So the signs of like a good baby that never cries and just kind of plays by themselves could actually be signs of distress as well. And what we try to do with these families is improve the quality of interactions and improve the quality of relationships so that caregivers can provide that warm, sensitive, and consistent care. Come on to the next slide, please. So I think we got the sense from Melanie that services are often complex and kind of multi-layered. So I wanted to share a little bit about how Little Minds Matter fits within the wider network. So if I can get the first clip, please. So Little Minds Matter is this early intervention prevention service that you're now very familiar with. Now, if I can get the next click. And we're part of Better Start Bradford, which kind of like Melanie's description of Better Start Blackpool has the same sort of 3 outcome categories of which we are really trying to harness the social and emotional well-being. And the next click. And we're funded by the National Lottery. One more, please. And reducing inequalities in cities. So we've got these 2 funding arms that essentially help us to deliver our service across Bradford City. So Bradford City and District is sprawling, but we're just focused at the moment on the inner city areas. So the 3 most deprived wards of Bradford, which are covered by Better Start Bradford, and the other inner city postcodes, which are covered by the Reducing Inequalities in City programme. If I could get one extra click, please. Organisationally, and this is where it gets quite interesting, we sit as part of CAMS, and parent infant teams across the country often sit organisationally in different places. And even Little Minds Matter, when we first launched as a service, we sat as part of the 0 to 19 children's service. So already you start to get a sense that there's a little bit of, this is a good service, but who owns it and where does it sit within the local context? And if I could get one extra click, please. So we're delivered as part of the Bradford District Care NHS Foundation Trust. So we are an NHS organisation, But again, I wanted to just highlight that that's not the case for all parent-infant teams. So although we work within the NHS, parent-infant teams might also find themselves in other local contexts, in the third sector, for example. And if I can get the next slide. So, and one more click, please. I wanted to demonstrate that the baby is at the centre of lots of services here in Bradford. We are extremely lucky that there is not an absence of will, expertise, or desire to support babies in terms of infant mental health. So I thought I'd just give a quick kind of whistle-stop tour of some of these services to give a bit of a flavour of kind of how they contribute to supporting parent-infant relationships and social and emotional development in infancy, which is really what we mean by infant mental health, that babies have a really good experience of a relationship with a primary caregiver, and that they are able to grow to regulate their emotions and learn from the world around them. So I've mentioned Little Minds Matter. The next service that's on the slide there is the Specialist Early Attachment and Development Team, the SEEDS team. This is another specialist service that sits within CAMS, and they're a 0 to 6 service, so a wider age range than the conception to 2 service that we offer in Little Minds Matter. And really their focus is on how do we support babies who have experienced maltreatment and abuse. So they use the child-parent psychotherapy model, which is a longer-term intervention to try and support parents and babies where there has been that really high level of risk in terms of safety and having the baby's needs met. So far, you'll notice that I've only really spoken about infant mental health services, and you might be thinking, well, where are the perinatal mental health services? And we've got plenty of support for perinatal mental health in Bradford as well. So first of all, we've got the perinatal support service. We're really fortunate that this is another Better Start Bradford project. And the aim of the perinatal support service is to provide that kind of peer support network for mums who are struggling with low to moderate mental health difficulties in that perinatal period. They're complemented by our perinatal mental health service, which in Bradford is called the Specialist Mother and Baby Mental Health Service. I feel really fortunate that the Specialist Mother and Baby Service exists in Bradford because they're a really parent-infant informed perinatal service. So I saw in the chat earlier that we've got a few perinatal services who have joined us today, and it's lovely to have you here. And I think it's really worth celebrating when we've got perinatal services that do a wonderful job of holding babies in mind, as well as thinking about the psychological and emotional distress that parents and particularly mums can bring. We've then got baby steps, and baby steps has been mentioned in the 2 talks that came before me as well this morning. So this antenatal education program. And I thought it'd be worth putting something about the local authority offer as well, and particularly around early help and prevention. And I think that there's scope for that to be more parent-infant focused, but certainly there is a local expectation that relational concerns in childhood can be supported through the early help and prevention services. So that is what exists at the moment. And I guess it made me think a little bit about how these services came into being, what it means for practitioners to be thinking about so many services that could potentially help a parent or a baby who is struggling. And if I could have one click, please. I guess there's this kind of expectation that practitioners might have that all of these services should kind of fit together really neatly, that we should be able to work in partnership really harmoniously, that it should kind of create kind of a whole that is greater than the sum of its parts in a really neat approach. But the reality of that is a little bit different. And if I could get one more click. Oh. One more click again, sorry. So the reality is that it's a little bit messier than that kind of expectation that practitioners might have. So there are different thresholds of needs, and I've already given some examples of those already. But certainly an expectation that practitioners who are looking to refer a family, or even a family who's looking to see what support is available to them, should be able to identify, well, hang on, what level of need do I have here, and therefore which service might be best for me. One more click, please. Geographical restrictions as well. So Bradford has given us a really brilliant opportunity to pilot and to trial an infant mental health service in the area, but it is restricted around postcodes. And that's the same for baby steps and the perinatal support service, which are also geographically restricted. So again, we're starting to ask practitioners not only to think, what's the level of need here for the family, but also to think, and where are the family? Where are they actually based? And the next slide, please. We also see this tendency towards drifting towards children who are of an older age range. So as soon as you say that you're a 0 to 19 children's service, you've got the withdrawn baby who might be quite easy to ignore for some of the reasons that Ben mentioned, or you've got the kind of teenagers who are showing their distress in a much more disruptive and challenging way for services to respond to. So the wider the age ranges become, the more there's this drift towards the older ages. And that's something that Sally Hogg from the Parent Infant Foundation has articulated really nicely. Next, click, please. And last but not least, there has been this kind of historical focus on parental mental health and distress. And we have seen some of this kind of shift a little bit since the Early Years Review has been published by Andrea Leadsom, MP. But historically, I think there has been this push on, let's just get mums with perinatal mental health difficulties the support that they need. And whilst we don't want to detract from that message, that's a very important message, we mustn't shine the spotlight so far on mums with mental health difficulties that there is this baby blind spot that's left behind. And the next slide, please. So that's the expectation, the neat jigsaw on the left. But if I could get one more click. The reality is that we've got all of these pieces that are trying to do really good work, but that are hard for people to try and piece together if they're looking at the system. And it creates an environment, I guess, where babies are harder to hold in mind, the needs of babies are harder to hold in mind, and families can potentially get slip through the net. If we could get the next slide, please. I also wanted to share this kind of brief article that Jane Ellis and I wrote last year, which really tries to, I guess, give some validation to how hard it can be for practitioners to hold babies in mind. And I was really interested in finding out that the word infant derives from the Latin, not able to speak. So if we start to think about this baby blind spot, even the word infant describes that they don't have a voice, they don't have a place at the table. So for all of these reasons, we really have to try and help services, help practitioners to be able to hold babies in mind. So in Bradford, we started to think, well, how can we do that? How can we make this easier for practitioners and for families alike? If you can click onto the next slide for me. So we created a dedicated referral pathway for Little Minds Matter to come alongside the Specialist Early Attachment and Development team. And if you can click again for me, if you could give me the next 4 clicks, actually. So this shows a little bit of the pathway, thank you, that families can access. So rather than having to navigate services directly, they can come to a single point of access and we will help them to navigate to find the support that's right for them. If it's not Little Minds Matter or Seeds, we will signpost them to the alternative service. And if no alternative service is available, we'll capture that data and help to identify where the baby gaps are within our system. And if I can come on to the next page, please. This is a list of the benefits that we expect to receive. We only launched this last week, so it's hot off the press. But we really think it'll be an opportunity to make services more effective, easier to find, and ultimately support greater collaboration for families and practitioners. And the final slide, please. It might not be perfect. There's things that are missing, but it's certainly good enough. Thank you.
Matt, thank you so much. I appreciate how difficult it is. You're so respectful of time there, and we hurried you through the last slides. You're probably feeling like the service itself didn't get attention, but it's been brilliant to hear that absolute reality check on the challenges of a bit of what we're taking for granted with the 300 people who are joining us, which is we already believe that babies matter. we're already holding them in mind, and we can do this. It's just a matter of, you know, we might do it a little bit differently. So I think that's a really welcome space you created for us to say it's not like that, and so the wheel goes on. So there is a question here from one of our participants about in your situation, how did that collective not just collective understanding, but a collective responsibility, how did you reach that to kick this off? How did that happen for you?
So I think we looked internally within CAMS and just thought, you know what, we can't put the expectation on other practitioners to be understanding our thresholds, potentially making 3 different referrals that get kind of passed from pillar to post. We understand that babies can't wait, right? This time of the first 2 years is critical. So we realized that we had to just reduce some of those barriers. And that means that we have to kind of step up and try and shoulder some of that burden so that there's kind of no wrong door. So if somebody does get in touch and we think that the perinatal service is the best place for them, then we'll be able to help them navigate that process rather than having them scramble between different websites and different organizations.
And the one-stop shop, I think, is fabulous as well. And I've listened a bit to some work. I'm going to say Pauline Byrne, and hope I have her name right, as a lead AHP clinical lead in Scotland, who was seconded into Scottish Government at the time. And I heard her speak recently and talk a lot about what these thresholds and referral points and the holding of knowledge somewhere down the line, that by the time a child or family gets to you, they may not need, may have been satisfied by reassurance. So I spotted a phone number on your slide, and I wanted to ask you about that. Is that, can anybody lift the phone to that number and get some kind of guidance and help or direction to what type of help might be available?
Yes, absolutely. And we're also launching a self-referral pathway so that we don't just say, oh, you've got to talk to a practitioner. We're wanting families to be able to access us for support as well, particularly as we now have these resources on our social media pages. It might be that actually a bit of reassurance is all the family needs, but knowing that there's someone that they can contact that will point them in the direction of those resources is really important. So yeah, we don't want to turn people away. We want people to come to us, and we'll help them as best we can. Absolutely.
And there's interest in your article as well, Matt, so you're going to have to stick that in the chat. There's a lot of interest there in where people can get hold of the papers. I know you're only a week off the ground, so it might be unfair to ask, but is there a kind of like a woohoo moment in terms of the response you've got to this first stop shop, or an already recognized challenge? Because I think people will be interested in some of that early learning as well.
Yes, I think first of all, it's been very well received by services like the perinatal team to think we don't need to worry about which parent-infant relationship service we go to. We just go to this one place. It has been very well received. Internally, we've still had some challenges of there's some gray area that even we're working out. Is that you or is it me? You could imagine that if this happens, it would be you, but if that happens, then it's us. And we're absolutely still finding our feet with that for sure. And it'll be a journey we continue to go on.
Well, you sound like the man for the job, Matt, and all credit to you and your team. Thank you so much. It was a fabulous presentation. I really appreciate that. Thank you. I'm going to bring Sarah Salem in, and we've had so much mention of fathers this afternoon. Sarah is Father Inclusivity Senior Project Officer at Small Steps, Big Changes in Nottingham. And there's a very long title here. Will I read it or will you read it after me? Recognizing the importance of positive paternal mental health and improved emotional outcomes for infants. So it's been a bit of a wait, Sarah, but we know from the comments in the chat that you have a really captive audience for this presentation. So we wish you the best.
Thank you so much. Hi everyone, thank you for having me today. I work at SSBC based in Nottingham. So in this short presentation, I'll be briefly demonstrating why it's important that the mental health of the father is acknowledged, particularly during the perinatal period, when considering mental health outcomes for infants. At SSBC, our focus is currently on fathers actively involved in the lives of their children aged below 4 years. Where a child has 2 primary caregivers, these primary caregivers will naturally adopt different parenting roles and responsibilities. Both of these contributions are vitally important to the developing infant. Both primary caregivers deserve mental health support to enhance their contribution to their child. Next slide, please. So fathers do not just play a genetic role to birth outcomes, as Ben alluded to earlier. We know from evidence that maternal behaviours during pregnancy are largely influenced by the father. So for example, the main determinant from research of whether a pregnant woman quits smoking is the smoking status of her partner, yet expectant fathers are not targeted antenatally for smoking cessation advice. The same goes for mental health. The mental health of the father and his behaviour has a profound impact on the mental health of the mother during the pregnancy. Spikes in cortisol caused by maternal stress have been evidenced to affect the developing fetus, influencing the area of the brain involved in mental and social development, as well as leading to potential complications such as premature birth. Numerous studies have suggested that fetal cortisol exposure can lead to greater irritability of the newborn, which invariably exacerbates parental stress after birth. Hopefully this slide demonstrates that fathers have a twofold influence on infant well-being through both direct genetic link and also the interactions with the mother. Fathers are therefore influential on the mental and physical health outcomes of the infant long before birth. Despite this, fathers do not receive targeted care. The care they do receive, if any, is incidental to the care provided to the mother. Next slide, please. So here's a list which can often and does so frequently give rise to postnatal mental health difficulties. I formulated this list. I used to be a health visitor, so these are the sort of general factors that I came across in women and men suffering from postnatal depression. I'd like you to have a look and consider whether any of these do not also influence the mental health of the father, whilst he's also transitioning to parenthood. So I'll give you a little time to have a read through. So often parents experience these factors together, yet often the advice is only given to one parent. In addition to these factors, often fathers can find it difficult to prove self-worth in their role as a parent to family members, to professionals, and to themselves. This matter of self-worth is often the trigger for mental health difficulties or can be a catalyst to existing low mood. And you will get these slides after, so if I haven't given you enough time, I do apologise. Next slide, please. So this slide is in relation to prevalence. So we can see that fathers experience perinatal depression at a clinically significant rate. 8 to 10 out of every 100 fathers are experiencing perinatal depression, and yet there is no standard practice in place to detect nor treat it. When a father experiences poor mental health, the child experiences this too, as the illness is present within the caregiving environment. Particularly so if mental health is present in both parents, as we can see here again, is the case at a clinically significant rate. We know that men are less likely to disclose details of mental health, and numerous studies into paternal mental health have found that fathers will prioritise the well-being of their partner and the baby over their own and choose to suppress feelings of low mood. But ultimately, untreated postnatal depression can lead to worsening symptoms and can give rise to other behaviours such as substance misuse, relationship breakdown, and even domestic abuse, which have further negative implications for children. Next slide, please. So how does parental mental health impact the developing infant? We've heard quite a lot about that already. This slide demonstrates the way in which poor parental mental health impacts different stages of baby brain development. But to explain more broadly the importance of social input to babies, it's useful to know that most animals are born with a fully developed brain or experience full brain maturity very soon after birth. They largely rely on instinct for survival, alongside early and brief practical teachings from their mother. But humans are social creatures who rely heavily upon interaction and connections with others for survival. Babies are born extremely early compared to animals with less than 30% of their adult brain size. Postnatally, the baby's brain connections are hugely dependent on the caregiving environment generated for them by their primary caregivers, with the brain doubling in volume within the first year. By age 3, the brain is 80% developed in terms of volume and processing. This demonstrates physiologically that early interactions and observations give rise to lifetime behaviours, including mental health factors. Qualities such as mental resilience, empathy to understand the feelings of others, and reciprocity are skills developed in infancy and exercised through a lifetime. Reducing the impact of poor parental mental health on infants relies on early detection and treatment, and this applies to all primary caregivers. Next slide, please. So here are 2 diagrams that were generated recently by Oxford University's CoSpace study on the impact of COVID-19 on parental and child wellbeing. Both mothers and fathers took part. So I'll let you have a look at the correlations there. I added these as I feel that the graphs side by side demonstrate the correlation between parental stress and children's mental health symptoms, and shows just how receptive and reflective children are of their parents' emotional state. Children really are the sum of their experiences, but vitally it's important to consider that most will not discriminate when it comes to their parents. Next slide, please. Here we see the universal package of care given to mothers across the UK to screen and support pre and postnatal mental health. So we have anything from 7 to 10 contacts with the midwives, at which case most of them will be, most pregnant women will be asked whether they're experiencing mental health difficulties. And that depends on parity, which basically means how many children they've had before, state of health and social concerns, etc. The health visitor antenatal appointment, which typically occurs between 28 and 32 weeks, includes screening questions for mothers about the way that they're feeling emotionally. The midwifery postnatal contact, which takes place between sort of 0 and day 10 of the baby being born, will have screening questions about how the mum's feeling. The health visitor new birth visit also asks screening questions about how the mother is feeling. The GP sees the mother at around 6 weeks, again, to ask how she's feeling emotionally. The health visitor then visits 6 to 8 weeks to ask how the mother's feeling emotionally. And then if implicated, and I know that this is standard across some trusts across the UK, but health visitors can also do a 3 to 4 month review, at which time they will also be asked screening questions. But none of this exists across the UK for fathers routinely. There may be pockets of good practice, and we've definitely heard about that today. However, until we standardise practice, which is fortified by national clinical guidance, of which there's a massive absence, and performance indicators, we are underserving this vast but underrepresented group. So next slide, please. So we at SSBC recently commissioned a consultation with local fathers to better understand their needs and experiences of Nottingham City services. Here are some of the quotes which came out of the research, which demonstrates the way some fathers have been made to feel about their importance of their own mental health. I'll allow you to have a read, and I would encourage you to consider yourself in their shoes of these fathers who felt these emotions during a particularly vulnerable time of their lives. Sorry, you've gone too far, that's it, thank you. And again, you'll get these slides at the end, so if you haven't had a chance to read, I do apologise. The full report is available on the SSBC website if you'd like to have a look. Okay, so moving on. So next slide, please. Perfect. So what are we doing locally to support paternal mental health? So we're raising awareness amongst our channels locally of the important influence paternal mental health has on child outcomes. Currently, we're working with the 0 to 19 Children's Public Health Service to create a simple father's flow chart for practitioners to follow when concern is identified to sit alongside the perinatal mental health pathway. We are supporting partner organisations to access the training needed to support staff confidence in detecting and responding to paternal mental illness. We have developed a resource for new and expectant fathers that contains information to support fathers' mental health alongside local NHS signposting to empower fathers to be proactive about their own emotional well-being. This resource is also hoped to act as a prompt and a tool for practitioners to be more father inclusive in practice. We held the consultation with fathers. Again, you can see the report on our website to better understand the experiences of fathers and to guide and rationalise all the work that we do. And we continue to have regular consultation with local fathers. We are working with partner organisations to support the provision of father-friendly groups. We are exploring the gap in health record keeping when it comes to fathers. This is particularly important when considering that mental health care provision relies heavily on the history of disclosures being documented, and that's pertinent to any future clinical support that they receive. And we're establishing father inclusivity as a core value within the establishment of our parent and infant relationship service. Next slide, please. So here are the broader ways that we are working to promote father inclusive practice within Nottingham City. So we've produced a father inclusivity strategy and operational plan. We have regular consultation with local fathers and share the learning across the partnership. We have a father-inclusive practice group, which is a multidisciplinary collection of individuals who share a passion for father-inclusive practice with the aim of driving forward progress. We respond to relevant government policy calls for evidence. We are redeveloping our Think Dads training offer to bring it in line with present evidence, which is available to all practitioners within Nottingham City. We have commissioned the IHV perinatal mental health training for the 0 to 19 team with a view of commissioning the father's perinatal mental health training later when the service has capacity to complete this. Again, we're celebrating and sharing best practice across the partnership. We have a service setting checklist to support services in making their venues more father inclusive in terms of imagery. And also we produce resources and infographics to support and prompt father inclusive practice. So if you could just take us to the next slide, please. This is just a snapshot of the first draft of the resource that we produced for new expectant fathers. So as you can see, it has a smoking cessation advice, but also it has critical advice to tell fathers what the issues to look out for and how to go get help from the NHS website, or there's the local IAP services signposted at the bottom. Okay, so next slide, please. So to conclude, where a child has 2 primary caregivers, the emotional well-being of both parents is important to consider when assessing and reducing the potential influence of poor mental health on the developing infant, both pre and postnatally. And that's the end of my presentation.
Thank you, Sarah. Thank you so much. I mean, I have to be totally honest and say, like, I felt a profound sense of sadness in some of the experiences that you shared there. You had a quote from a dad on one of the slides that said, "I might as well not have been in the room." So you talked about unmonitored, unroutine, and incidental care of fathers there, and it sparked 2 thoughts in my head. So let me share the first one with you, which is, if that's how we're treating dads who are there, i.e. we're presuming them to be a caregiver who comes to appointments or is at home. I know my own husband's experience of that when the health visitor came out on those early visits was, "I don't think she wants me here," or I think she thinks I'm here in case you ask her any awkward questions, like, so that he felt judged and possibly in a negative way, rather than seeing or feeling himself to be involved and to have information that he might share about that bonding experience appropriately with her. It's a personal experience, but one to be acknowledged. So what about dads who aren't there? If fathers are estranged in terms of the relationships, are you able to reach those fathers, and what kind of work can you or do you do with and for them?
So with estranged fathers, I guess the response is when they became estranged. I'm very, very passionate about the importance of early intervention when it comes to father inclusive practice. So I do genuinely feel, and this is backed up from evidence, that if we get it right, so really we're talking in pregnancy, if we involve the father, we make sure that a father knows how critical he is to that caregiving environment, to the role that he will play in that infant, then actually, if that father then chooses not to engage with services and chooses not to be part of that child's life, that then I feel forms a really important part of the assessment that is made by a practitioner as to the support networks that that mother receives. So I think it's important for 2 ways, that we try, but if we try and they don't engage, then that actually tells us how that situation is for that family.
I know another question that's come in, which is the second part that I wanted to go to, but it's actually come up now from a participant, is we're talking about fathers and those experiences of dads, but where are we, and this is fair or unfair to target to you, Sarah, but your presentation raises a question in terms of same-sex couples. Where is that experience of the second parent as secondary, regardless of or because of their sex?
So we do try in the things that we write to talk about non-birthing primary caregivers, because they would be included in this as well. It's it's not a separate subsect of parents, but it's getting the gendered language correct in resources. So we are at SSBC open to adapting resources for same-sex couples, but that requires a separate consultation. I do think it's a very, very worthwhile area of work, but for now, SSBC is not honing in onto that yet, because actually, if we think about if we think about the population, the vast majority of non-birthing primary caregivers are fathers. And right now we're not getting it right across the country. So until we address that, until we make progress there, it's difficult to then branch into those even more underrepresented groups.
And Sarah, in terms then of the kind of size of population that you're working in, typically like a child population, a family population, where is the kind of, what are the levels of engagement and participation where fathers do want to be included in the type of work that you're doing? And I know you're already touched on this a wee bit, but where the stance possibly is one of disengagement, because it occurs to me that in the modeling that we do with our children, you're entitled to change your mind, you know, and that could come, there could be all kinds of reasons for dads feeling or fathers feeling, and I'm now careful of our language in terms of the non-birthing parent feeling, that there's just not a role for them here. Is there a way to do work that might allow them the space to become re-involved?
Yeah, I think it's getting it onto every practitioner's agenda, so that, you know, it's not just midwives, it's not just health visitors that are mentioning the importance of fathers. It needs to be GPs, it needs to be anyone that comes into contact with a family, you know, schools, for example. There was a piece of research done into dads who received letters from school addressed to parent/carer, and it was shown that the vast majority of the time the dad would just pass that on to the mother because they didn't actually consider themselves that person, that parent/carer. So I think that it's everybody's responsibility to be more father inclusive, to try and pave a world where there is less of a gender bias and less of a societal view that men are the ones that go to work and women are the ones that look after the children at home. It's a very archaic view. We've made a lot of progress in the world in other areas, but this is one area that really the progress really is worrying.
Sarah, thank you so much. I'm going to give a heads up to the other presenters that I think your presentation gives us a place that we might lean into a wee bit in the final questions, which is the gender bias and the experience of the non-birthing partner. So for those contributors who've gone before and yet to come, I think I'll come back to that a wee bit. But thank you so much for your presentation. Thank you, Sarah. Thank you so much. I'm going to bring our final contributor and thank her already for waiting, because I've been in those shoes, and that's a fabulous place to be when you're hearing everybody else and then you realize, oh, I need to get my stuff ready and up on screen. So Dr. Ellen Ottey is the clinical lead at the Essex Parent Infant Mental Health Service in Southend. I'm going to hope that I can see Ellen appearing on my screen very shortly. And this is a pre-recorded contribution, and this is about shifting or changing the trajectory. So yes, I see it.
Morning, my name is Dr. Ellen Ottey, and I'm here today to talk to you about infant mental health and to introduce the Essex Parent Infant Mental Health Service, known as Together with Baby. For some of you will already be familiar with our service, for others this may feel new, but I welcome your thoughts and discussions. I'm sorry I'm not able to be with you in person today, but if you'd like to get in contact, please do email me on the address on this slide. So this week is Infant Mental Health Awareness Week, and what do we mean by infant mental health? Well, we reference this as the infant's social and emotional well-being. And today I'm going to talk to you a bit about how this develops and the importance of this for the baby's future growth and development. So why is infant mental health important? Well, it represents a window of opportunity. The first 1001 days of a baby's life are a period of unique and rapid growth, when babies' brains are shaped by their experiences and their environment. Without a stable and consistent environment in which the baby can grow, the costs to the developing child and the future adult are high. The economic costs of adversity are costly. For many of our adults struggling today with poor physical and mental health, as well as limited life opportunities, came from environments where the beginning of life was difficult. Taking the metaphor of a shakily built house, you can try to fix things, to patch things up, pouring money in and resources, but until it is acknowledged that the foundations are poor, then and needing strengthening, the house will remain shaky and unable to do the job it was designed for effectively. Human beings need strong foundations so they can flourish and make positive contributions to their communities and society. These foundations are laid down in pregnancy and in the first 2 years of life. This is where the social and emotional brain is shaped and the individual's emotional and social style and resources are established. The development of the social brain relies upon a positive relationship with a caregiver, primarily the mother, but others caregivers offer enormous influence to the infant's emerging relationships. As you'll be aware, the baby arrives primed, ready to attach to a caregiver, enabling a relationship to be formed. This attachment will be governed by physiological and psychological processes, giving the infant the best chance to find a safe caregiver who will protect and care. A baby attaches and a parent bonds, suggesting that the baby brings the ability to connect and the parent brings the ability to strengthen the attachment into something lifelong. Our experience of attachment has been widely researched and has led to an understanding of being a universal experience, one that is robust and crucial to influencing our ability to relate to others and form secure relationships. Once attached to a caregiver, the baby then needs the ongoing input of a caregiver to grow the essential brain architecture to help regulate emotions and social experience. The baby arrives with the essential brain capacities to govern survival, and this we share with other mammals. However, higher human brain capacities that govern cognitive, social, and emotional development grow over time, and in some cases entirely outside of the womb, such as the frontal cortexes. Babies arrive with raw material ready to be shaped and grown. Each one comes with a genetic blueprint and a range of possibilities. The baby human has various systems ready to go, such as digestion and breathing, but many more are incomplete and will only develop in response to another human input. Some have referred the postnatal infant as an external fetus to capture the fragility and vulnerability of a newborn, but also the incompleteness and the needing to grow further. Some speak of the newborn being programmable, ready to be imbued with cultural and social influences. This makes sense from an evolutionary point of view, as human culture can then be passed on to each generation. A baby arriving in a remote village in Nepal will have a very different social experience to one born in an urban high-rise in a London borough, both needing to adapt to the social worlds in which they find themselves. Sue Gerhardt, an infant psychotherapist, speaks of the infant being born with vibrating, pulsating symphony of different body rhythms and functions which coordinate themselves through chemical and electrical messages. Within the baby are many loosely connecting systems which overlap, and the systems communicate through these electrical and chemical messages. But in the first few months, the baby is trying to keep things comfortable, whether it's managing changes in temperature, hunger, tiredness, thirst, pain, and comfort. The body will experience the arousal changes in how it feels comfortable or not. Some will feel more sensitive than others. Some will be more sensitive than others, but all will be trying to find their set point, a bit like Goldilocks, too hot, too cold, just right. Learning to tolerate this process is vital, but it can't be done alone. Setting this point of arousal is defined postnatally. It's an adaptive response, one that cannot be predefined, as it would leave the infant vulnerable should circumstances change. Think of a baby born into a household of 6 children to one born into a house without siblings. There will be differences in the noise, the demands on attention, and routines will vary considerably. The setting of arousal into a normal range, what I can tolerate in the beginning and in time, and what I can regulate, happens through the relationship with the caregiver. The caregiver helps to coordinate the systems, naming the feelings, helping to adjust the environment for the baby, and assisting to soothing. For example, when you hear a parent speak to a newborn as they cry, you'll hear the, "Oh, what's up? Are you feeling upset? Or what's going on for you?" When this goes well, babies come to expect a world that's responsive to feelings and is helped to bring these intense states back to a comfortable level. Through these experiences, having it done for them, they learn to do it for themselves. This experience of having it done for them comes from the parents who don't have a guidebook, who until that point have been handed their infant, know what to do with their baby. However, somehow they do it. They find a rhythm. They understand the beat of their baby's emotions and experiences. They make sense of them, drawing upon their own emotional narratives, and manage to create a dance of interaction that allows the baby to grow. This is something we call synchrony. Slide. For some parents, these early beginnings can be incredibly difficult, and to discover your programs and you will be parenting can raise all sorts of challenging experiences. The phrase intergenerational transmission of trauma captures how parents can often feel terrified, numb, angry in the face of their baby's vulnerability. They were once a vibrating, pulsating infant who was born into an adverse environment, and their caregivers' abilities to help them tolerate and regulate their emotional and social experiences were compromised. They grew adapting along all manner of responses to manage the world around them through school, home, and into work and relationships. They now find themselves as parents, and what can they do to draw up, or what can they draw upon to help their infant? Selma Froberg's seminal paper, Ghosts in the Nursery, speaks to this difficulty, acknowledging the difficulties and in many cases the trauma of being parented by a parent who could not do this safely, with love and care, and find their own neglected infant state surfacing when faced with their own infant's vulnerability. What could a parent do? They may avoid, they may react, dismiss. It's easy to see how that relational trauma transmits through the generations as each parent feels ill-equipped, helpless and scared. When things go well, a parent can experience their baby with warmth, delight in their infant. When things go less well, a parent can experience a baby as intrusive, demanding, and often there's little joy in parenting. We know in our early years work the impact of adverse childhood experiences, ACEs as they're known, and the corrosive effects of poverty, domestic abuse, addictions, untreated or unstable mental health issues can have on young people. Acknowledging the importance of infant mental health and establishing those building blocks in human growth enables us to fight harder. It gives us the economic and societal argument to invest in preventative work. Shifting the trajectory, redirecting the course of development brings opportunities for the infant to fulfill his or her potential, to have a different template of relating and to find healthy relationships. This week is Infant Mental Health Awareness Week, and the Parent Infant Foundation, a national charity that advocates for infant mental health, has issued a new report called Baby Blind Spots. And I'd encourage you all to seek out this report on their website. There is also one called Babies in Lockdown, which was released last year. Both of these reports highlight the imperative to bridge the gap in infant mental health. At the moment, so much of our focus is on child and young people's mental health, and quite rightly so. However, what we're campaigning for this week is to begin to bring in infant mental health into the narrative. So when we're directing our colleagues in commissioning, in our governments and in our support of services, that we include infant mental health as a core to the foundation of working with children, babies and young people. I'd encourage all of you today to think about the blind spots in your services or the blind spots that you've come across in your role. What is missing when we think about babies? Where are they in the thinking? Where are they in the service delivery? Where are they in the offer that we give to parents and families in Essex? We're fortunate to have an Essex infant mental health service here, known as Together with Baby. And I'm very proud of this service and to be leading this service, and along with my colleagues who are listed here on the slide. We've been operational since January 2019. And we've had a tricky start given we've had COVID to manage with, but we have continued to see families throughout these last 18 months, continue to take referrals, continue to work remotely where possible, and in some cases continuing with our face-to-face visiting. We are hoping very much that as the restrictions lift, that this will start to change and we'll be able to see more and more families in settings which they feel most comfortable, whether that's their homes or in family hubs and centres across Essex. We're based at Cherry Trees in Malden, which is at St Peter's Hospital. However, the service is delivered across localities. So our staff that you see here today are located within the localities of West, Mid, North, East and South. And if you're wanting to know who your locality person is, then please get in contact with us and we will get you in touch with them. So how do we help? How do we support families that I referenced earlier who are struggling with the difficulties that they may have experienced when they were infants and children and now finding or resurfacing or coming to the fore as they become parents themselves? Well, we offer specialist assessment. We offer consultation to referrers, and we've actively encouraged that because we understand that for some referrers this may be the first time that they've referred to the service and there may be confusion or not sure about whether our service is appropriate or not. So we always encourage people to pick up the phone and talk to us. Specialist assessment will take place with the family over a period of time, often includes video, where we get a chance to look at the interaction between the parent and the infant. And as you've noticed all along that I'm referencing parents, so we work with both fathers and mothers, as well as mothers from same-sex relationships and fathers from same-sex relationships. So we are open to all aspects of parenting. We offer a range of interventions should the assessment identify needs that to support the family further, and it can vary depending on that need. For some families, parent-infant psychotherapy is indicated because there's a need to really think about their experiences of being parented themselves, to help them process the difficulties and trauma they've been through. We're then looking to integrate their relationship and their difficulties there with their current relationship post the therapy. We also look at using video through a video interaction guidance, which is a way of examining the micro interactions and seeing what the baby's communicating to us, because babies are very active in their communication, but often as parents we might miss those cues, and video can be really helpful for parents in understanding what's going on between them between them. We also offer circles of security, which is another video approach. It's a parenting program in a sense that it gives parents a framework in which to understand attachment and bonding and what might go wrong in that relationship. And we find that hugely effective because it gives a really strong narrative for parents to understand what the baby is needing from them as a parent. Often what parents get stuck on when babies are seeking their parents, they will do two things. They will either head out away from their parent to explore, and they're seeking their parent to follow them and to be with them as they go on their exploration, which increasingly takes wider and wider circle. as the baby grows. For some parents, that can feel really challenging, to allow their baby have exploration and to be free in that exploration, and to take delight in that, to be playful with that, to have that experience of being noticed and being curious, because their own experiences were not that. There's also, for the baby, that what we call coming in on the circle, which is where they'll seek from the parents comfort, soothing, organising of an experience, what has gone on. So you see this frequently in babies. They'll head out, they'll seek something, they'll be interested in something, they might check back to their parent, and then something might happen that they're not sure about, or they lose confidence with, or something causes them discomfort, and then they return back to their parent. And it's that circle that we support parents with. And I could go on a lot more about that, and our trainings that we give to services are an opportunity to learn more about these approaches, but hopefully that gives you some idea. Weight Watch and Wonder is a really nice intervention that supports parents to be curious about their baby's exploration and play, and being able to allow space for their baby, and to be able to wait and see what their baby does and invite them into those interactions. We offer a lot of training and supervision, as we feel very passionate about increasing the knowledge and understanding around infant mental health, but also what to be looking for when working with families. And we're very keen about building the network. So events like this, we really value attending, because it gives us a chance to reach out for people to understand what we're about, and as well as have those dialogues with services about how we can increase the awareness. And thinking back to the slide around bridging that gap, really think about what can we do together as services to really strengthen the support that we give to families in these early few days. So if you're interested in finding out more about us, or you want to refer, then we really encourage you to get in contact with us. So you can either contact me directly on the email I gave at the beginning of this presentation, or there's the service email here on the slide. You can also call us on the numbers here, and we're really happy to be able to think through referrals with you, think through with your service. I'm very keen to be having more conversations with services about what we can be doing to instill more information and awareness raising ideas within services that surround a family, and supporting the information that parents clearly need, but at the moment that information can feel overwhelming and confusing. So we've got some really good resources that we're happy to share, and it'd be great to have conversations with you on the call today, should you wish to. Thank you for listening today. I wish you the best for the rest of your day. I hope you will be looking out for the infant mental health awareness promotions that will be going on this week. I'm certainly going to be sending out lots of information via email, but look on Parent Infant Foundation website, and also on their Twitter feed, because they're putting an awful lot out, as well as the Association for Infant Mental Health. So I'd encourage you to have a look there. Well, thank you for listening. I hope that.
Thank you so much. That was a cut short. Thank you, and bye-bye. Thank you to Dr. Ellen Ottey for making time to give us that contribution by video. I had loads of questions for you, for you all, and I'm going to have to pull my thoughts together and then invite a kind of final comment from each of you. Let me tell you the big things that are still swimming around out there in participants' heads. One is about commissioning and how we bring them with us. How do we convince commissioners there's a particular interest in the prenatal period and in dads? How do we, or how have you brought them with you? I'm thinking about that gendered experience of infant mental health as a parent. And I also wonder if there is a kind of there are words of encouragement that you would give more general mental health, community education, family support services about how they can actually hold babies in mind and help us address the baby blind spot, so that we're not doing this in 10 years time. So from all of that potential, and we literally probably have a minute each, what's the final thoughts or comments or words of encouragement that you would like to share, both with our participants and in turn that they might share with those that they're persuading around these arguments? I'm going to invite Ben to come in, because you looked like you had a thought formed in your head.
Don't be deceived. Well, I know it's a bit of a well-worn phrase, but it's this kind of working together about raising awareness. And I know that Matthew mentioned about these jigsaw pieces, and I know that I mentioned about perinatal teams, and kind of helpfully a couple of perinatal nursery nurses or community nurses said, that they do work in the relationship too, and equally parent-infant teams work with adult mental health. So it's finding these creative crossovers that don't always fit so well, and it's events exactly like this, which is bringing different localities, practitioners, disciplines, agencies together, that I think collectively, as that quote said, there's no single service, no single practitioner. It's that creative tension between us that we can maybe take that to commissioners together, rather than, because things tend to be a bit siloed and in kind of different boundaries really. So that would be my main message. I know it's a well-worn phrase, but working together and bringing that.
Thank you, Ben. Couldn't say it enough. Melanie, would you like to come in?
Yeah, I think Ben helped me there, because he went first with that, but I think it's all about the C's. So it's about us all working collectively, creatively, and helping staff with that competency and confidence, so that we can all be part of that family's journey at whatever that our role is in that, along that trajectory. So yeah, all the C's.
Thank you, Melanie. Sarah?
I agree with what my colleagues have said, and I would also say that we do need a system change in relation to fathers, but that relies on individual change. And so if every professional does what they can do, within their limits to engage fathers in practice, I think that will be supportive for children.
Lovely, thank you. Matt?
I'll pick up your point about how do we work with commissioners. And I guess the thing about blind spots is that we don't always know that they're there. So passionate practitioners explaining to commissioners that the 0 to 2 part of services are often missing, and CAMS is child and adolescent, not infant, child and adolescent. And I think making that case and making that case well, commissioners will listen. And certainly that's been our experience in Bradford, has been that once we've explained the case for change and used the resources on the Parent Infant Foundation website, commissioners have been really receptive to that. They often want to work preventatively. It's just, our job as passionate practitioners to help them.
Brilliant, Matt, and you bring us expertly back to the theme, of this Infant Mental Health Awareness Week, and to the fact that, we can use evidence and lived experience to convince commissioners that this works, and it delivers for them as well. I want to thank all of you, all of the team at NCB and Beacon House for making this happen, and all of the work that you do on an ongoing basis. If you as panelists or participants get to enjoy more events this week, do enjoy them. If it's a case of being kind to yourselves and smiling at babies and mummies and daddies as you see them, I think that sometimes makes a difference to people's day. So we're going to let people away respectfully on time. It's been a huge privilege to chair this and hear from you, and the presentations will be available after today. So go easy, people, into those small places close to home where big changes happen. Thank you all very, very much. Thank you.
Thank you.